For today's class, we'll be dealing with X-rays, and in the subsequent class, we'll deal with the rest like immunization, drugs, etc. Okay, instruments. Now, how do we go about it? Interpretation. Then we'll go system-wise: neonatology, respiratory system, CVS, GIT, genitourinary system, and finally the bones. Now, so first, let's start with the basics of how to interpret an X-ray. Now, once you're given an X-ray film, you can't just directly point out in an example the pathology you're finding it like you're finding a consolidation. So you can't just jump in and say that you're finding a consolidation in right upper lobe, for example, correct? You have to interpret it systematically. One is because you might miss out on other findings. Two, and the examiners will like it if you go systematically and interpret it likewise, correct? You'll have to, if you are given an X-ray film, you'll have to go about systematically. And how do we go about it? So when given an X-ray, first thing you'll have to comment about is whether it is a plain X-ray or a contrast X-ray, followed by comment on which part of the body the X-ray is taken. For example, if it is from the chest, then you'll have to tell a plain X-ray from chest. Then if you're this you might ignore as well, not needed now. If you're interpreting an actual X-ray, then you might have had to look into it. Then you'll have to see which is your right side and which is your left side. Then comment upon the view, whether it is an AP view, PA view, lateral view, oblique view, or a supine X-ray, or a lateral decupitous X-ray, whatever it is, comment on what the view is. Then talk about the exposure, whether it is underexposed, overexposed, or correctly exposed. Then you see whether the film is centered properly or not. Then if you're talking about chest X-ray, most of the chest X-rays you'll have to interpret it in an inspiratory film because that gives out more of the findings, correct? So you'll have to tell whether it is an inspiratory film or expiratory film. Okay, then systematically examine each part of the X-ray. So if given a chest X-ray, you'll have to examine all the parts of the chest X-ray, not just the lungs, correct? So we examine each part of the X-ray. And finally, the last thing you do is comment about any abnormality. Okay. So that is how we systematically go about interpreting the X-ray film. Next is, how do we tell whether it is a AP view or PA view, correct? Now, the difference between AP view and PA view is basically AP view is taken from a close. It is taken close from you. If you are here, it's taken closely, correct? So distance between the X-ray film or yourself and the X-ray beam projection is just less than 6 feet. So in that case, what happens? The X-rays go tangentially as compared to PA view, wherein it is taken from from 6 feet or 180 centimeter. Over here, the beams would have become parallel. So because of this tangential direction, what happens is it seems as though it is magnified. So whatever X-ray you get, if you get a cardiomegaly, you can't interpret it from AP view because since it is going like this, it is going tangentially, it seems magnified. So that is the difference between AP view and PA view. So in AP view, X-ray beam passes from anterior chest wall to the posterior chest wall, correct? Whereas in PA view, it just passes from posterior to anterior chest wall. An AP view is usually done bedside, correct? So it is preferred in unstable patients who are admitted in ICU, OT, or as an emergency procedure. But this is used in OPD practice in a stable patient, okay? As already explained, over here, the X-rays beams are not parallel, correct? That is why it passes tangentially. So what happens is mediastinum appears magnified, okay? As compared to parallel rays, there is no magnification over here. That's why we can comment upon cardiomegaly in the case of PA film as compared to AP. Then how do we, by looking at the X-ray, how do we tell whether it is AP or PA view? One is look at the clavicles. In an AP film, clavicle is seen above the apex of the lung fields, correct? As you see over here, these are the clavicles. It is seen above the apex as compared to PA view, wherein it is seen over the lung fields, correct? Over here, you see it over the lung fields. So this is one way to make out Next is the scapula. What you see, the inner borders are seen over the lung fields. For example, look over here, the inner borders come somewhere over here. This is where you see the scapula as compared to a PA view, wherein you see the scapular borders in the periphery. Okay, so this is the next point. Finally, ribs, anterior ribs are better visible when it comes to AP view, and posterior ribs are better visible when it comes to PA view. So that is how you differentiate AP view from PA view and the differences. Okay, these are the basic questions that will be asked in your Viva. Next, coming to exposure. How do we tell whether a film is correctly exposed or not? So you see there are three different X-rays given over here. X-ray A, B, and C. This is underexposed, this is correctly exposed, and this is overly exposed. So only a correctly exposed X-ray can be interpreted in the right way. Correct? That is what we know. Now, but how do we differentiate it? How do we look at the film and tell whether it is correctly exposed or not? So what we do is go back and look at the intervertebral space. Okay. So a correctly exposed X-ray, as we see over here, as we look at the B image, what happens is the intervertebral disc spaces, what you see, they are just visible, they are finely visible. Okay, if the intervertebral spaces are just visible or finely visible, okay, that means it is correctly exposed. Whereas you compare to a overly exposed, what you see over here is they become very clearly visible. They become very clearly visible. In that case, it will be overexposed. Like you might get confused that there are no lung markings over here. It is a bilateral pneumothorax, you might as well say. But what is the problem is it is a overly exposed X-ray, correct? And how do we tell that? The intervertebral space, what you see, is very much clear. You can trace it down to the bottom, correct? Now, when it comes to an underexposed X-ray, over here we are unable to see the intervertebral disc spaces itself, correct? Over here we can only make out one or two disc spaces. Other than that, we are not able to look at the disc space itself. So that is how we differentiate an underexposed from overexposed and a correctly exposed film. Now, next thing we'll be commenting about is rotation, whether the X-ray is placed centrally or not. Again, if it is rotated, you might get confused thymic mass to a consolidation if it gets rotated, correct? So how do you differentiate a rotated film? So that is the next thing you will be commenting about. So a rotated film, whether it is correctly placed film, centrally placed film, or rotated, the way we tell is we draw a midline. Okay, we draw a midline over here and look at the end of the clavicles. Look at the end of the clavicles. If it is equidistant, if the ends of the clavicles are equidistant from the midline, that means that it is not rotated. It is a centrally placed X-ray. It is a good quality X-ray, and you can go ahead and confidently comment about it. Whereas you look over here, this is a rotated X-ray because look at the distance. Look at the distance, correct? So this is how we differentiate a rotated X-ray from a correctly positioned X-ray. That is what is explained over here. Both both medial ends of clavicle should be equidistant from the midline. Okay, from a vertical line drawn through the center of T1 to T5 vertebral bodies. If it is rotated, the medial end of one clavicle appears further away from the vertical line. So that is what has been explained. Next is how do we tell whether it is inspiratory film or an expiratory film? In an inspiratory film, one is the dome of the diaphragm corresponds to the anterior end of 5th to 7th vertebra. Okay, so the dome of the diaphragm, what you see, corresponds to the anterior end of 5th to 7th vertebra. So now if we trace the anterior end, 1, 2, 3, 4, 5, 6, correct? So it is a correctly inspiratory film X-ray as compared to expiratory film wherein it will be less than 5th rib. So over here 1, 2, 3, 4 and 5, correct? So this is an expiratory film and this is an inspiratory film. The problem with expiratory film is the diaphragm will become pushed up. So you might miss out a consolidation which is hiding over here. You might miss out a consolidation that is hiding in your right lower lobe, correct? So that is why we prefer inspiratory film over expiratory film. Okay. So then you comment about whether it is inspiratory or expiratory. And as the diaphragm is pushed up, you might see apparent cardiomegaly as well in an expiratory film. It mimics basal lung collapse and increased blood vascular markings are seen at the lung bases. So these are the disadvantages. One is you might miss out any pathology that is present in the lower lobes. Next is apparent cardiomegaly can be present. Then it mimics basal lung collapse. And one more is increased blood vascular markings will be present at the lung bases. Okay. Now, next is how do we systematically examine each part of the X-ray? So now, for example, you're given a chest X-ray. Now, this is how I have been taught. There is many methods. One is inside out approach. One is outside inside approach. Or there is A, B, C, D, E, F, G, H approach. So there are many approaches, but whatever you do, it is fine. But for the examiner, you will have to interpret it systematically. That's it. Once you interpret systematically, the examiner will be very much impressed no matter what. So what I will be teaching today is inside out approach. Okay, from inside we go to the outside parts. Okay, so first comment about the trachea, whether it is centrally placed. Look at the trachea, correct? It is visible to you, I hope. Whether it is centrally placed or displaced, whether it is laterally pushed, if pushed laterally, whether it is right side or left side. Okay. Next, look at the superior mediastinal structures. Look at the superior mediastinal structures. What happens very often is you guys are oriented to adult X-rays, correct? So when it comes to an infant X-ray, you might get confused to a mass or a consolidation which is present in the superior mediastinal structures. You might think it to be a consolidation or you might think it to be a mass, but it is nothing but a thymus, what you see. If at all it is a rotated X-ray, you will think about it to be a mass. You will think that it is a right upper lobe consolidation, correct? So be careful. Most of the times it is a thymus what you see. Okay, so in the superior mediastinum, comment about the thymus over here. See, this is what we call as the classical sail sign, correct? It appears as though the boat-shaped structure. Now it appears as though the because of the boat-shaped structure, so it's called as the sail sign. Okay, this is the thymus. Fine. Next, you comment about the aortic arch. Next, you go ahead and look at the aortic arch. This is the aortic arch. Okay, fine. Next, what you see next is the aortic knuckle. This is the aortic knuckle. Might not be very prominent in pediatric patients. Okay, so trachea followed by the superior mediastinal structures. Then comes the aorta and the arch of the aorta. Then comes the aortic knuckle. Then you go ahead and look at the hilar shadows. Okay, hilar shadows. These are the hilar shadows. In the hilar shadows, what you get? You get nothing but the main pulmonary artery, dividing it into right and left pulmonary artery and its branches. Okay, so this is the blood vascular markings what you get. And one more thing what you can comment about is over here in the palatal region, if you have some mass like this, most of the time it is a lymph node mass, correct? You can comment about parahilar lymph node. In case of, for example, in a case of TB, you might get a parahilar lymph node. Okay, so these are the parahilar structures which you comment about. So that is what you can see, main pulmonary artery dividing into right and left pulmonary artery. Then you'd comment about the cardiac borders, whether there is cardiomegaly or not. Okay. After the cardia, you come lower down and look at the diaphragm. Look at the diaphragm and structures below the diaphragm. Diaphragm and the structures below the diaphragm. After that, comment about the cardiophrenic angle. Whether any obliteration of cardiophrenic angle is present. Then finally, comment about the chest wall structures. If there is any bony abnormality of the chest wall. And finally, the last one is the lungs. Okay, you divide the lungs into 3 zones: upper, middle, and lower. Upper, middle, and lower zones, and then comment about each pathology, compare left and right, left and right, left and right, and then go ahead and comment about each structures. So this is the inside out approach. Okay, first thing, look at the trachea, then come down, look at the superior mediastinal structures, then come down again, look at the aortic arch and aortic knuckle, then comment about the parahilar structures, then come even more down and look at the cardia. Next is diaphragm and subdiaphragmatic structures, chest wall abnormalities, and finally the lungs. Divide into 3 zones and compare each zone. Okay, left and right. So that is how we systematically examine each part of the X-ray. Now, finally, to summarize, if you are given an X-ray, so this is a plain X-ray belonging to the chest. Okay, whether it is, this is the right part of the X-ray, that is the left part of the X-ray, AP view, adequately exposed, it is well centered, inspiratory film. Okay, and then you comment about each part. So that is how we interpret the X-ray. Now, whichever X-ray we are going to see, though I will be directly going into the pathology, if whenever you're given in the exam, go systematically. Finally, you comment on whatever abnormality you see, like whether it is whatever abnormality it is, comment it this way, whether it is unilateral or bilateral, whether it is a symmetric lesion or asymmetric lesion, whether it is a focal lesion or diffuse, whether it is radiolucent or opaque, and whether it is focal or diffuse. Okay, so if you see a right upper lobe consolidation, then you tell that there is a unilateral symmetric focal lesion present in the right upper lobe which appears opaque, and it is focal. Okay, so that is how we comment on the abnormality. Now let's look at any doubts till now. No doubts on YouTube also. Centering of the X-ray means whether it is placed in the center or whether it is moved off into one of the corners. Okay, that's all it means. Any other doubts on YouTube or on Zoom, or can we go ahead to the next topic? No, it is not the same as rotation. Rotation is from the intervertebral space midline to the clavicle. Centering means the whole film as it is can get pushed off into one side, correct? That is that is the difference between centering and rotation. Next is, okay, so next topic we'll deal with is neonatology. Okay, now neonatology, obviously you can't take a PA view because you cannot make a baby stand erect, correct? So one difference is it is almost always taken in AP view until and unless we ask for a special view, it is AP view. Okay, then again a superior mediastinal structure, that is thymus, is most of the time prominent. So don't get confused or taken away as to it is a collapse or a consolidation what you see, or a mass that you see. Most of the times it will be thymus. Okay, and normal CT ratio is more because of the AP view what you see, so there will be apparent cardiomegaly. So and one more thing is an infant X-ray is more of right side dominant X-ray, so you will have some amount of cardiomegaly in neonates and infants. So normal CT ratio what we take is 0.6, and diaphragm is up to 8 ribs posteriorly and 6 ribs anteriorly. Okay, so these are few of the difference between neonatal X-ray as compared to pediatric. Neonate and infant as well, most of the time. Neonate and infant X-ray as compared to pediatric X-rays of other age group. Okay, now firstly coming to respiratory distress syndrome. Over here, what is the pathology? Basic pathologies in preterms, like less than 34 weeks. What happens is there won't be enough surfactant, correct? Because there won't be enough surfactant. Surfactant is required for the lungs to expand. Okay, so the lungs remain collapsed. So there will be some part of the lungs which would have expanded. There will be some part of the lungs which is still collapsed because there is not enough surfactant required for it to expand, correct? So what happens? There will be some collapse, there will be some consolidation, there will be some hyperinflation. So it will be bilateral patchy involvement, correct? Because there can be atelectasis. In the same time, there can be collapse. In the same time, there can be overinflation. Everything can take place in one lung because of the absence of surfactant. Few parts which have some amount of surfactant might get expanded. Other part might get collapsed, correct? When this collapse and consolidation happens, there can be some amount of obstruction to the airway, which will, so the lungs can become hyperinflated, correct? So there will be a mix of pathology. So what you get is bilateral involvement of fine granular appearance. Okay, so this is the first stage. Then if it further progresses, it can have ground glass appearance, and the last and final stage is white out lung. Okay, so again the pathology will be bilateral and symmetrical, and air bronchograms which you see extend peripherally. Okay, so now based on the severity, stage 1 is bilateral, symmetrical, fine reticulonodular opacities, correct? So you see streaks of, okay, these reticulonodular opacities which are extending from the center to periphery, okay, which is bilateral, correct? So these are the reticulonodular opacities which you see in stage 1. Stage 2 is this reticulonodular opacities are present. There will be decreased transparency. Okay, then there will be blurring of the diaphragmatic margins. Along with this, you can see air bronchograms that extend into the periphery. See, you see one air bronchogram here, you see one more here, you see one more over here. If you see correctly, correct? This is stage 2. And fourth one is diffuse whiteout lung. Final stage is diffuse whiteout lung. So what do you see in respiratory distress syndrome? Bilateral, symmetrical, fine reticulonodular opacities. If it becomes worsens, there will be air bronchograms, and then the final stage of ground glass lung or full whiteout lung. Okay, so this is what you see in respiratory distress syndrome. Then comes transient tachypnea of newborn. Next pathology. Over here, what happens in fetal when the baby is still not yet born? The lungs are filled with fluid, correct? The lungs are filled with fluid. Once the fetus comes out of the womb, there is a transition from fetal to the infantile circulation, correct? Once that happens, the air goes out into the lungs, the fluids are pushed out, correct, from the interstitium, and from the lungs it is pushed out into the interstitium, and from the interstitium the lymphatics takes care and pushes out all the fluid. Okay, this is what should happen normally. If this transition doesn't take place, if this transition doesn't happen smoothly, what happens is there will be some amount of fluid collection still left within the lungs, and some amount will be pushed out. That will lead to collection of lungs in the interstitium, correct? So what happens is, and this fluid which is left out in the lungs might cause obstruction, which will lead to hyperinflation of the lungs. Okay, next there will be interstitial edema because of the fluid, and what happens is you will get the classical sun-ray appearance. Okay, the interstitial edema becomes prominent, so you will have this sun-ray appearance as you see over here. See, there are streaks going, correct? So this is the sun-ray appearance. Next, one more characteristic finding is prominent right upper lobe. The fissure of the right upper lobe becomes prominent. That is what you see over here. Look, I hope it's visible. I'll draw it for you. Right upper lobe, the fissure becomes prominent, correct? And rarely you can get cardiomegaly as well. So these are the changes you expect in transient tachypnea of newborn. Next is Meconium Aspiration syndrome. Now, what happens in Meconium Aspiration syndrome? The baby would have swallowed the meconium because of the intrapartum stress it undergoes. as the baby is coming out, the baby, if the baby undergoes some amount of stress, it will end up swallowing the meconium. This meconium, which it gets swallowed, the baby accidentally aspirates it. Once it gets aspirated, it will go settle down in the lungs, correct? And this surfactant, sorry, with this meconium which goes and settles down in the lung, one, it can cause chemical pneumonitis. Two, it will go and damage whatever surfactant that is left. Okay. And three, it will go obstruct the airways. Correct. So because of these three pathologies, first one was what? It will go and cause chemical pneumonitis. So bilateral fluffy opacities you get because of bilateral consolidation. Second thing is you have again a picture like RDS, which will lead to the ground glass appearance of the lungs. Three, it will lead to airway obstruction. So there will be hyperinflation. So these are the changes which you can expect in meconium aspiration syndrome. So what you get is bilateral, diffuse, heterogeneous, fluffy opacities. See, it is bilateral, diffuse, and full heterogeneous, fluffy opacities. All these things are because of the chemical pneumonitis. This is suggestive of patchy areas of atelectasis and emphysema from air trapping. Correct? Atelectasis is because few of the airways gets blocked and that part of the lung will collapse. Correct? That will lead to atelectasis, and there will be again airway obstruction can cause emphysema. So there will be hyperinflated lungs. Okay, hyperinflated lungs, and finally it might cause air leak, which will lead to pneumothorax as well, because the as it is fetal lung is gentle. Upon top of this, there is so much of pathology which will lead to the alveoli breaking up and causing air leak. Okay, so there can be patchy opacities. It is patchy because the few areas will get into atelectasis, few areas will enlarge and become emphysematous. So that is why it is patchy. And these emphysematous lungs, because of chemical pneumonitis, there will be consolidation in them. That is why there are patchy opacities, and there will be air trapping leading to hyperinflated appearance. So this is meconium aspiration syndrome. Next is esophageal atresia. Okay, can anyone differentiate what is the difference between the first X-ray and second X-ray? What is the difference? Both are esophageal atresias. So anyone can make out the difference? On YouTube, anyone? Okay, no one is replying. I'll only tell. The difference is both of them are esophageal atresia only. One is making communication with the stomach below, the other one is not. So the esophageal atresia, what you get is 70% of them present as tracheoesophageal fistula. Okay, so in tracheoesophageal fistulas, you will have to know the types. There are 6 types, which is the most common type. All those things you should know. And what you get is the coiling. You see the NGT that is passed is coiled over here. Again, I'll show. The NGT that is passed is coiled over here. Correct? This is the coiling which you get in tracheoesophageal fistula. And 10 to 15% of esophageal atresias are isolated. Okay, so what happens in isolated esophageal atresia is you have the esophagus here and there will be atresia. So there is no communication between the esophagus and the stomach below. So there is no swallowing up of air that is taking place. When this happens, you will not have the gastric bubble over here. The shadow of the gastric bubble won't exist. Correct? So that is how you differentiate. Okay, so X-ray, in both the X-rays you have coiling. See, over here also you have coiling. Over here also there is coiling. Correct? The NGT that you pass will not be able to pass, and once you take X-ray, there will be coiling. The difference between isolated esophageal atresia is you will not have the gastric shadow over here. Fine. Next is the congenital diaphragmatic hernia. Obviously, CDH, the most common type is the Bacterial type, which is left posterior type. And the rarer one is the Morgagnian hernia, which might not present in the neonates as well. They might present later in the life. Okay, so what you get, ipsilateral hemithorax contains bowel loop filled with gas. Okay, so and the lung that is present over here in that part is hypoplastic, along with mediastinal shift to the opposite side. See, what you see is trachea is shifted to the opposite side. The left part of the lung, you see the bowel shadows over here, and there is no lung left in the left part of the lung, correct? So the lung is hypoplastic. So this is how you recognize an X-ray of CDH. It is pretty easy. Next one is duodenal atresia. What all can be the causes for duodenal obstruction in a newborn? One is duodenal atresia, or then you can have the pancreas rolling up over the duodenum, which is causing the obstruction of the duodenum, correct? Then you can have CHPS, which can appear as duodenal atresia. Right? So there are many causes of duodenal atresia. Okay, duodenal obstruction, one of the causes duodenal atresia. And whatever be the cause of duodenal obstruction, what you get is the characteristic double bubble appearance. Double bubble appearance. Okay, so one is the gastric shadow of the stomach, other one is the initial part of the duodenum. Okay, so the double bubble appearance. Next, let's look into the respiratory system. Now, respiratory system, the basic thing is the anatomy. Wherever the pathology is, you'll have to know the initial anatomy of the respiratory system to tell that that particular pathology is over there, correct? So this is the right upper lobe, and right upper lobe is over here in a lateral X-ray. Next is the right middle lobe. This becomes the middle lobe, right middle lobe, and the same in a lateral X-ray, correct? The right middle lobe abates with the cardiac margin, and that is why you get the Silhouette sign. Whenever there is right middle lobe consolidation, it goes and obliterates the cardiac border, what you call it as the Silhouette sign. Next is the right lower lobe. Okay, now the advantage of taking a lateral X-ray is when you have a consolidation over here, correct? So now you don't know whether it is a right middle lobe pathology or a right lower lobe pathology, correct? So in that case, if you take a lateral X-ray, then you will be able to tell if the consolidation is over here, it is right middle lobe. If it is over here, it is the right lower lobe, correct? So this is the advantage of taking lateral X-ray along with the AP or the PA view X-ray. Now coming to the left part, you don't have three, you just have two with the lingula. So this is the left upper lobe, okay, along with the lingula, left upper lobe with the lingula, and the same on the lateral X-ray, and this is the left lower lobe. Okay, so this is the basic anatomy. If you are confident with the anatomy, now we can go to the pathologies. Okay, so the first one is the infection. We'll initially deal with the viral infections and then the bacterial. Okay, now coming to the viral infection, first one is the bronchiolitis. Bronchiolitis caused by the respiratory syncytial virus. Okay, so we all know, and what happens is because of the inflammation of the airway in the bronchiolitis, okay, so there will be inflammation of the airway, and two, there will be secretions in the airway. Okay, so if this is the normal caliber of the bronchus, because of the inflammation, there will be thickening of the wall and there will be pooling of the secretions, correct? So what happens? The airways becomes narrowed, correct? So that is what happens in bronchiolitis. Airways become narrowed, correct? So what do you see? Because of the narrowing of the airway, there will be some amount of obstruction and air trapping. So there will be generalized bilateral hyperinflation of the lung. Once the lungs are hyperinflated, the diaphragm will be obviously pushed down, okay, along with translucent lung fields. Okay, diaphragm is pushed down, okay, and you will see more than 8 spaces if you count, correct? You will see more than 8 spaces, so it is hyperinflated lung fields along with flattening of the diaphragm. Okay, this might be one of the picture. One more picture can be parahydral peribronchial infiltrates. Okay. See over here in the parahilar peribronchial region, there will be infiltrates, correct? Because of the inflammation that is taking place. So these are the two spectrums which you can find in bronchiolitis. Okay. Next, coming to viral pneumonia. Now the characteristic of viral infection is whatever the clinical signs which you find, or on auscultation, whatever clinical findings which you find, or the X-ray feature, it is bilateral. You cannot localize it. Okay, the virus spreads and affects both the lungs as compared to bacterial infection, wherein most of the times localization is possible unless it is an atypical infection. Correct. So characteristic of viral infection, as you saw in bronchiolitis or in a viral pneumonia, it is bilateral. Okay, so that is one thing. Localization is not possible. And again, viral pneumonia can involve the interstitium. Once the interstitium gets involved, there will be, as we already know, as we saw in RDS and all, there will be bilateral streaky reticulonodular appearance. Correct. As you see in this X-ray, there is bilateral streaks going, reticulonodular opacities. Okay, bilateral reticulonodular infiltrates will be present from the center extending into the periphery. That is one pattern. One more pattern is of alveolar pneumonitis. If it involves the alveoli, then there will be consolidation. Correct. Again, since it is viral infection, it will be bilateral involvement. Okay, so bilateral nodular fluffy infiltrates, fluffy consolidation. Okay, see, you find one consolidation here, one over here, one over here, one over here. So it will be bilateral nodular fluffy consolidation. If it is alveolar pneumonia, rarely, and most of the times this is how a viral pneumonia presents. It will be interstitial in nature. Okay, next is we are done with the viral spectrum. Next is the bacteria. In bacteria, usually localization is possible. Okay, so we'll see different types of bacteria via infection. One is the lobar consolidation. In this pattern, see, you get a clean lobar consolidation. Correct. There is a opaque structure in the right upper lobe caused by, most of the times this is caused by streptococcal pneumonia. One of the example is streptococcal pneumonia. Or you might have multiple pneumatocysts. Correct, multiple pneumatocysts. Okay, this usually occurs characteristically with staphylococcal pneumonia. One more example is Klebsiella pneumonia. Okay, then you can get what is called as the bulging fissure sign. Bulging fissure sign. Correct. The fissure of the right upper lobe is pressed downwards. Okay, pressed downwards, which will lead to the bulging fissure sign. And this is seen in characteristically with Klebsiella pneumonia. Okay, so these are the examples. Then comes the atypical pneumonia. Atypical pneumonia, as already told, it is interstitial pneumonitis. It will resemble your viral pneumonia. Correct, interstitial pneumonitis of the viral pneumonia. So you will get bilateral reticulonodular opacities. Okay, now for example, causing atypical pneumonia is Mycoplasma pneumonia or the chlamydia pneumonia. Like you have this X-ray. This is of a child with HIV. So this is of a child with HIV who came with tachypnea and significant respiratory distress with low saturation, and this was the X-ray taken. So what do you suspect over here? Anyone would like to answer? On YouTube, anyone would like to answer? Yes, Kunj, very good. This is a PCP pneumonia, pneumocystitis carni pneumonia. Good, Akshay. This is one more cause of atypical pneumonia. Next, you have the tuberculosis. Now, tuberculosis, the X-ray which you get in the medicine department or adults is significantly different from the pediatric X-ray. Okay, because in pediatrics there can be, one is the primary that can occur up to 5 years, and the other one is the secondary, which comes in adolescents and adults, and it will resemble your adult thing. Okay, so what happens in primary is when the first infection is taking place, okay, there will be one of the foci in the periphery, okay, that will lead to the consolidation foci in the periphery, what we call it as the Gons focus. Okay, so there will be a consolidative patch, And from here, the bacilli goes spread through the lymphatics and involve the parahilar lymph nodes, correct? So you will have a lymph node involvement as well. Okay, both these things together are called as the Gons complex. This is the primary form. Secondary form is the usual cavitary form which you get. Okay, so this one is more common in the right upper lobe, and this one is common in the peripheries of the upper part of the right middle lobe. Okay, and it will usually be in the periphery. Okay, so this is again a primary tuberculosis wherein you have a parahilar lymph node with the Gons focus over here, and this is the secondary tuberculosis. You will see the cavitation over here, correct? So these are the two types of tuberculosis. And how do you differentiate cavity? Cavity is usually you had pneumatoceles over there, and now you are having a cavity. How do you differentiate this? Usually this is thick walled as compared to a pneumatoceal. It is thick walled cavity. Okay, so you will have a consolidated alveoli. Okay, and inside the alveoli there is necrotic cyst taking place, which has led to the cavitation. Okay, that's why it will be thick walled. Next is croup. So croup, it can come as epiglottitis, which is a very serious presentation. One more is the ALTB, acute laryngotracheobronchitis. In acute laryngotracheobronchitis, what we get is the characteristic steeple sign. Okay, why do we have this steeple sign? Because there will be subglottic narrowing of the airway. Since it is laryngotracheobronchitis, since these parts are involved, and the narrowish part of the infant's airway is the subglottic region, the subglottic region will easily get narrowed down, correct? So that is why you get the steeple sign. Okay, and over here, as the epiglottis is thickened, what you get is the thickened epiglottis, which is characteristic called the thumb sign of epiglottitis. Next is the lung abscess. Now, how do you differentiate a cavity from the abscess now, correct? In lung abscess, you have a picture similar to cavity along with air fluid column, because in abscess there will be collection of pus. Once there is collection of pus, you will get the air fluid column, correct? So you have thick wall along with air fluid column. Okay, so that is to deal with the infections. Next is collapse. Okay, how do you see a collapse? Now over here you are making out a right upper lobe opacity, correct? There is a right upper lobe opacity. This could as well be a consolidation, correct? Even a consolidation appears the same. You will have a right upper lobe patch or right upper lobe opacity, correct? An opaque structure will be present. But how do you confidently tell that it is a collapse and not a consolidation? How do you differentiate it? Is over here you see the rib space. If you observe carefully, there is compensatory hyperinflation of the right lower lobe and the right middle lobe. Because the right upper lobe has collapsed, this has taken over its space. Okay, so there will be compensatory hyperinflation. That is why you see that the lungs are more translucent because of the thickening. There is more space between the ribs because of the again hyperinflation, and the bronchomuscular maskings which you see, when you see over here, it is so closely spaced. When you see over here, it is widely spaced, correct? The bronchovascular markings are more widely spaced, the ribs are more widely spaced, and the ipsilateral lung appears more hyperlucent because of more air filling as a result of hyperinflation. So if there is compensatory hyperinflation, then you call it as a collapse, or else it is consolidation. Yeah, that is what is mentioned over here. You will have the same white homogeneous opacity of consolidation, but what is the difference is there will be compensatory overinflation of the adjacent lobes, and yeah, trachea or mediastinal shift can be taken place to the affected side. See over here, the trachea is shifted towards the right. Okay, and vessels are more spread out. So this is how we differentiate collapse from a consolidation. Now, what happens in a left upper lobe consolidation? What happens over here is you get this something called as Luftsichel sign. So what is this is, over here there is consolidation. Okay, over here there is consolidation. You can make out. Now, I think so. Sorry, I told left upper. It is the left middle lobe collapse, not the left upper lobe collapse. Okay, sorry, made a mistake. If when there is a left middle lobe collapse, as you can see over here, there is a collapse of the left middle lobe. Correct. What happens? The left upper lobe hyperinflates. Okay, when this happens, you get a sickle shaped. Okay, you get around the aortic knuckle. You get a sickle shaped radiolucency. Okay, that is because of the compensatory hyperinflation of the upper part of the left lower lobe. Okay, so that is I'll again explain it clearly. I only went wrong. I only got confused. There is collapse of the left upper lobe. Okay, there is collapse of the left upper lobe as you see over here, and there will be compensating hyperinflation of the left middle lobe or the lingula and the left lower lobe. When that happens, there is a radiolucency. There is a radiolucency that is around the aortic knuckle. So left upper lobe collapse, you will have Luftzischel sign. Okay, fine. So that is was to deal with the collapse. Next is pneumothorax. How do you identify pneumothorax? It is easy. There is absent because there is no lungs itself. The lungs have gone and collapsed over here. There will be absent vascular markings. Since air has come out of the lungs, there will be increased size and lucency of the inward hemithorax. Okay, and since that part is pushing that much amount of air is pushing the trachea and mediastinum, there will be shift of the mediastinum to the opposite side along with the flattening of the ipsilateral diaphragm. Okay, that was pneumothorax. Next is pleural effusion. Pleural effusion, what will happen? There will be this is the costophrenic angle. There will be blunting of the costophrenic angle. Means the costophrenic angle is not visualized. Correct? Look over here and look at the left side and look at the right side. There is blunting of the costophrenic angle and there is opacification. Okay, opacification. And since the X-ray beam moves tangentially, there is S-shaped curve of the Ellis. Okay, S-shaped curve of Ellis can be seen. So this is your pleural effusion. Okay, so I think so most of the respiratory system X-rays are done. Okay, next is the cardiovascular system. Again, coming to cardiovascular system, you will have to be confident about the anatomy first to comment about the pathology. Correct? So what we see is the left one, the left atrium. This is the left atrium and this is the left atrial appendage. Okay, so here we have the left atrium, here we have the left atrial appendage. So left atrium doesn't form any of the borders of the heart except for this small part formed by the left atrial appendage. Okay, next you have the left ventricle. This is the left atrium, this is the left atrium. Next you have the left ventricle. Okay, and this left ventricle forms the apex. Okay, this left ventricle forms the apex. Okay, then you have your right atrium, then you have the right atrium over here. So the right heart border is formed by the right atrium. Okay, the left heart border is formed by the left ventricle. We'll see what is the significance. Okay, we'll see what is the significance of this in our later X-ray. And this is the right ventricle. This is the right ventricle. So this part is formed by the left atrium, left atrial appendage. The left heart border is mainly formed by a left ventricle. The right heart border is formed by the right atrium, and this is the right ventricle. This was to do with the PA view. Now coming to the lateral view, the anterior part forms the right ventricle. Okay, and this forms the right atrium. So this border forms the right atrial border, this border forms the right ventricular border, and this is the left ventricle. This is the left ventricle and this is the left atrium. Okay, so these are the markings, these are the anatomy. Okay, so the first pathology we'll be seeing is cardiomegaly. Cardiomegaly, what happens? The CT ratio, if of newborns and infants, as already told the reason, is 0.6, and older children, it is the same as adults, it is 0.5. How do we see CT ratio? How do we comment upon it? Again, draw a line, central line over here through the intervertebral space. Okay, draw a straight line. Then you take the farthest distance, okay, farthest distance, and make a marking over here, make a marking over here, and then you measure this distance. Measure, you add this distance with this distance, two farthest points to the right and the left, and then finally calculate the distance as a whole, okay, and you take the ratio of these two. Okay, this is how we measure the CT ratio. Then comes the right ventricular enlargement. So what happens in right ventricular enlargement is, as we saw, this is the right ventricle, correct? This is your right ventricle, and when this right ventricle enlarges, it will push the heart up, okay, push the heart up because of the enlargement, because below is the diaphragm, it cannot go any further downwards. So the only way is to push the heart up. So in right ventricular enlargement, the characteristic finding is the upturned apex. Okay, as we saw over here, the apex is upturned. Okay, so apex is laterally and upwardly displaced and elevated from the diaphragm. And where all we can see right ventricular enlargement, you can have it in TGA, or you can have it in AST with Eisenmenger syndrome, or in a case of TAPVC because there's more flow to the right side of the heart, or in a case of EST or VST with pulmonary artery hypertension. These are few examples. Next is the right atrial enlargement. Right atrial enlargement, as we see, right atrium makes up the right border of the heart, correct? So what happens is a prominent convexity in the right side is seen, a prominent convexity on the right side. So right atrial shadow occupies more than 2.5 interspaces, okay, and distance from the midline to the right heart border will be more than 4 centimeters. These are few ways to tell that there is right atrial enlargement, and few conditions will be severe PS, pulmonary stenosis, or Epstein's anomaly, or tricuspid atresia. Next is left atrial enlargement. Now, as we already saw, the left atrium doesn't make any of the heart borders except for a small part over here, which makes up the left atrium. So what happens is, what we saw over here is, this is the usual after aortic knuckle. This is how the heart border is. But what we see over here is, there is straightening of this left heart border, correct? So if there is straightening of the left heart border, then it indicates there is left atrial enlargement, which signifies that the left atrial appendage has enlarged. And few of the conditions causing it is PDA, VST, mitral regurgitation, or mitral stenosis, what you get in rheumatic heart disease. Okay. Next is your left ventricular enlargement. Left ventricular enlargement, what happens is the apex is shifted down. As compared to right ventricular hypertrophy, there was upturned apex. Over here, the apex dips downwards. Okay. So the apex is shifted down and out. Correct. Apex is shifted down and out. Okay. It goes and abuts the diaphragm. Okay. And this happens in large VST, significant MR, AR, PDA with large shunt. These are the few conditions causing left ventricular enlargement. Okay. So we saw cardiomegaly, CT ratio, and each chamber enlargement. And next, coming to a few of the congenital heart disease and its characteristic appearance. This is staff with the boot-shaped heart, or core and support, what is called. This is mainly because of the cardiomegaly, which will lead to upturned apex without cardiomegaly. Okay, so the right ventricular enlargement has gone upturned apex, and since there will be stenosis, pulmonary oligemia will be there. There will be less amount of blood flowing to the lungs, so there will be pulmonary oligemia. The bronchovascular markings will be very less. Next is your transposition of great artery. Over here, you get, this is the string, and this is your, so this is the egg-on string appearance. Okay. Next is your Epstein's anomaly, and over here you get the box-shaped heart. Okay, because of the massive cardiomegaly, you get what is called as the box-shaped heart. And finally, TAPVC. TAPVC, what happens is there is enlargement of the right atrium and there is enlargement of the superior vena cava as well because of the increased blood flow. So the superior vena cava enlargement along with the right atrial enlargement will come out as the figure of 8 appearance or the snowman appearance. Okay, superior vena cava and the right atrial enlargement. Next is the final part of cardiac X-ray is the cardiac failure or pulmonary edema. Okay, so there are different stages in pulmonary edema. Any cause of pulmonary edema, one of the example is cardiac failure. Okay, there is interstitial stage and the alveolar stage. In the interstitial stage, if there is fluid accumulation in the interstitium, you get the reticular lines. This you guys already know. And what are these lines called? If these are small transverse lines in the periphery, as you see over here, okay, in the peripheries, if you have these short transverse lines, these are called as the B lines. Okay, and these large lines which come from the center going into the peripheries, these reticular lines are called as the A lines. Okay, these are called as the A lines. So you have the A lines and the B lines. Okay, if this further progresses, if the interstitium is not able to pump out all the fluid goes into the alveoli. Okay, so once the fluid goes into the alveoli, there will be consolidation, correct? And this consolidation doesn't involve the peripheral part of the lungs. So that is what you have the characteristic butterfly or the bat wing appearance. Butterfly or the bat wing appearance. So this is the interstitial stage and this is the alveolar stage of cardiac failure, or may it be any cause of pulmonary edema. Next is the GIT. In GIT, there are very few X-rays. First one is the congenital or infantile hypertrophic pyloric stenosis. Over here, what happens? The pylorus is stenosed, correct? So you'll have the single bubble appearance. Okay. And next question which they tend to ask is, since ultrasonography is diagnostic investigation of choice, what are the ultrasonographic findings? So here, muscle thickness of more than 3 mm or the pyloric length more than 15 mm or diaphragm more than 8 mm. These are the findings. Okay. Next is the Hirschsprung's disease. Hirschsprung's disease, what happens? The rectum will become aganglionic, correct? So whatever is above it will be dilated because below down it is aganglionated and it will mimic obstruction, correct? So there will be distended bowel loops throughout the abdomen will be present, and on doing dye study, what happens is normally what you have to find is rectum should be more dilated as compared to sigmoid colon, but over here in Hirschsprung's disease, because of the aganglionic segment, rectum is much more narrower and sigmoid colon is dilated. Okay, so these are the findings in Hirschsprung's disease. Next is pneumoperitoneum. Whenever there is intestinal perforation, there will be pneumoperitoneum, and the characteristic appearances, this is the diaphragm and you have air under the diaphragm. Next is the intussusception. Intussusception, you have the target sign in your ultrasound. Okay, and in X-ray you have the claw sign. In X-ray you have the claw sign. It appears as the claw because this part is gone inside and this part is like this, so you get the claw sign. Okay, this is what you get in intussusception. Next, coming to genitourinary system, only two X-rays are there. One is of the vesicoureteral reflex. Okay, so vesicoureteral reflex, you do the dye study, you do the micturition MUG study, micturition ureterography, okay, or widening cystourography. This is called as. Over here, once we give the dye, what happens is you can classify it into grade 1, 2, 3, and 4. Because there will be reflex, there will be the reflex of the dye from the bladder to the urethra. Okay. Now, what is grade 1? Reflex in there will be reflex, but the ureter is still not dilated. Okay. So it is reflex into non-dilated distal ureter. What is grade 2? Reflux up to the pelvic calyceal system. Okay. There is reflux up to the pelvic calyceal system, but still ureter is not dilated. That is what you see. You see reflux over here, grade 1. And over here, you see reflux throughout up to the pelvic calyceal system, but ureter is not yet dilated. Okay. Then there is grade 3, wherein you have mildly dilated ureter. Okay. So this is what you see in grade 3. mildly dilated ureter. Grade 4 is there is reflux up to the pelvic calyceal system, and the ureter is moderately dilated, and there will be blunting of the pelvic calyceal system. Okay, so there is blunting, correct? So that is what you see over here. There is blunting of the pelvic calyceal system with moderate dilatation of the ureter. And the final one is the grade 5. Over here, it is grossly dilated and full ureter becomes tortuous. Okay, that is what you see over here. There is gross dilatation with tortuous ureter. So grade 1 to grade 5 of vesicoureteral reflux. And then there is posterior ureteral valve. So how do you diagnose? Usually it will be antenatally detected bilateral hydroureteronephrosis will be there. And again, on doing dye study, what you get is dilated and elongated posterior urethra will be present on doing the contrast study. Okay, so this was to do with posterior ureteral valve. Okay, next, coming to last two x-rays, one is of rickets, other one is of scurvy. Okay, so rickets, again, vitamin D deficiency in growing bone causes rickets. So whichever part of the bone is growing, that part gets affected. Since there will be vitamin D deficiency, there is generalized osteopenia. That is what you note. There is generalized osteopenia in the cortex. Okay, next there is cupping, as you see over here. There is cupping of the end of the bone, end of the growing bone. There will be cupping, and there will be fraying. Fraying is nothing but these margins which you see over here. It is irregular, correct? These margins are irregular. This is what you call it as fraying. That is the next change. And then there is splaying. What is splaying? There will be widening of the metaphyseal ends, correct? See over here, the metaphyseal ends have widened. Over here as well, the metaphyseal ends have widened. So you'll have to know what is fraying. You'll have to know what is splaying. And finally, you'll have bending of the bones, which will lead to the anterior bowing or lateral bowing or the wing sweep deformity, whatever you get. As you see, there will be bending of the bones. So this is the changes you find in rickets. Once you know the findings of the rickets, next they will ask the changes in scurvy. So in scurvy, what will be there? There will be defective osteoid formation. Okay, since collagen is deficient, there will be defective osteoid formation in the bone. So again, the cortex, what you see, you will have the ground glass cortex. See, you are saying able to see that is ground glass, correct? And there is pencil thin ground glass shaft. Sorry, the shaft will be ground glass, and the cortex is pencil thin. It is highlighted, correct? So this is the pencil thin cortex. Then you will get the ring epiphysis. Ring epiphysis is nothing but all the epiphysis will be in ring shaped only, but the periphery of the epiphysis is enhanced. It looks enhanced, correct? You see, it is more white as compared to the center, correct? That is what you call it as ring epiphysis or the Wimberger's sign. Then you have the white line of Frankel, correct? This is the zone of calcification. This is the white line of Frankel. Below the white line of Frankel, you have a hypolucent area, correct? You look carefully, there is a hypolucent area, and that is called as the scorbutic zone. And in the periphery, you have the Pelton spurs. For example, if you look carefully, you have one Pelton spur here, you have one Pelton spur here, correct? And there can be subperiosteal hemorrhage as well, correct? There can be subperiosteal hemorrhage as well. Okay, so these are the findings in scurvy.